It's important to understand how clinical research goes about and how these new innovations come about. We don't just kind of come up with a little collagen marshmallow and hand it to everybody and say, go ahead and do it. There's very, very rigorous trials. And in order to run the trial, and they had two trials, one was a feasibility study and one was a safety study, the BEAR 1 and 2 trials. And what those were to test the hypothesis, make sure it was safe for everybody, and to see if it was working like we thought it was going to. And the one tricky part about those trials is everybody has to do the surgery in the exact same way. And one thing I can tell you from a single surgeon who's developed his techniques over the last 17 years is that as I feel, I can adjust the way I do things when new products come out, when stronger stitches come out, stronger anchors, etc. It allows me to adapt and innovate and iterate the techniques, which is something that you can't do when you have clinical trials. And so the early clinical trials on the BEAR 1 and 2, they have a slightly higher failure rate than reconstruction. But what I'd like everyone to take into consideration is that that was with the very first iteration of how to do the technique, which is a little cumbersome. And it wasn't using high-strength sutures, and to be honest with you, I haven't ever done that technique. I use the technique that I developed, and I've adapted the BEAR to add to that, and it's very effective in that regard. And so what you see is that there's the initial studies, and then it's released out to all the surgeons who are always trying to iterate and make it better. And I think what you're going to see is that with the newer modern techniques, the newer sutures, the newer physical therapy protocols, knowing a lot more about how to advance people, we're going to see that the failure rates are going to drop